Dear colleagues, I'm Nunay Kazan. I'm the director of Armenian Eye Care Project, and I present to you our so-called round rounds in ophthalmology, and this is one of our next sessions. And today, again, we will be presenting a new topic for you, and this is the pediatric ophthalmology, and in the frames. And we aim to widen these topics, and Armenian Eye Care Project is organizing this. Also, Malayan Ophthalmology Center and Yerevan State Medical University Department of Ophthalmology. This meeting will be led by Dr. Ruzana Harutyunyan. She's a doctor, PhD, Yerevan State Medical University Department of Ophthalmology. She's associate professor. And she's also the head of the pediatric department in Malayan Center. And we will have Mark Silverberg joining us today. He's a pediatric ophthalmology surgeon. And John Hovanesian is also joining us today. He's a member of the Trust of Armenian Eye Care Project. And today we organized our grand rounds in a way that the continuous medical education credits will be given to those participants that will fill the task completely after we have the lecture. I hope that the topic is interesting, and I hope it will enrich your knowledge in pediatric ophthalmology. You can put your questions in the Zoom Q&A section, and now I will ask Dr. Ruzana to continue. Thank you very much. Firstly, I wish you all a good day, and I would like to greet our favorite John Hovanesian. You are also participating today during this grand rounds, and I would like to greet my dear colleague, Dr. Silverberg, and he will be sharing this information with us today, and he will exchange his knowledge and experience with us, and I'm grateful for your presence today. And firstly, let me introduce our first talk. This is a calculating and selecting for pediatric cataract intraocular lenses, and we will share also our experience with this. We'll share our experience with our colleagues today. Let me introduce Anis Sargsyan, who will be presenting this topic. Thank you. The topic that I would like to talk today, it's about childhood intraocular lenses calculating and the approaches for selection of the lenses in pediatric cataract. So among children, about 10% of vision loss is the pediatric cataract. They may be congenital and acquired. They can be also combined with another disorders, including chromosomal disorders. Also, general syndromes and radiation, trauma. It may be also combined with other ophthalmological diseases, for example, persistent hyaloid or anterior segment issues, retinal issues. We have morphological and clinical variability, and we can see here different variabilities of cataract here. And what are indications for surgical intervention for cataract? So surgery does not imply that it will be removed. So we need to evaluate the effect of darkening due to cataract. Among the indication, we have opacities that are more than 3 millimeters, the central or posterior, unilateral strabismus with cataract, also nystagmus associated with bilateral cataract. Pediatric cataract is one of the main causes for obstructive amblyopia. So the surgery has to be performed as soon as possible. So the axis for the vision will be more clear, and the image will be on the retinal area. The surgeries are usually performed on children aged 3 to 4 months. In children that are less than 4 weeks, in this case, there is a higher risk for complications and complications due to general anesthesia. In older children, surgery is performed when visual acuity is 20 to 40 or less. Optical correction is performed with lenses and intraocular lens implantation. In children aged 1 to 2 years or older, we implement implantation of intraocular lenses. In children aged less, in case of unilateral cataracts, we usually use contact correction and closure of the healthy eye. If the issue is bilateral, then we use glasses correction first, and after 1 year of age, secondary implantation is performed. The primary implantation is performed at age 1 year of age or later. So if the cornea is more than 9 millimeters, microphthalmia, and also issues in the anterior part. In children that are aged less, the primary implantation is associated with higher risk for complications, and with age, there's higher probability for refractory issues. So studies have shown that in aphakic eyes, amblyoptic changes are happening, and this may lead to 8 dioptria. And it's connected to the structural changes. So in children up to 1 year of age, the refractory changes are a little more unexpected. For implantation of the lens, you need to consider the age of child, the refraction of the eye that is operated, and refraction of the other eye. So approaches are the following. In some cases, emmetropia is a result, especially in case of unilateral cataracts. So with this approach, in the future, there is performed a correction of exotropy in the future. And another approach, intraocular lenses are implemented later. So this is performed when the child needs correction for so we implement the law of 7 when the age between these two ages has to be 7. So if it's +5, then 2, +4 is 3, and this is calculated for each age. According to certain authors, in our clinic, we perform usually the law of 7, and we consider the refraction of the other eye. We perform appropriate correction in order to avoid anisometropic amblyopia. In order to estimate the power, we use different types of formula. For the neonates and infants, in order to calculate the force, this may be a little unexpected, because there is the factor of ocular development, also keratometry difficulties for the evaluation, and there are methods of evaluation that are mostly used for adults. According to different studies, depending on the axial length and depending on the age, the following formula are recommended. These are SRKT, center, Reslanti reticle, also a Barrett formula, Holiday 1, 2, Hoffer formulas, and others. In our clinic, the evaluation, when performing the evaluation, we consider the axis, its length, the depth of the anterior chamber, keratometry evaluation, the axis of the lens. We evaluate the refraction, also considering the refraction of the other eye, and the anterior axis and its ratio to the length. That's how the force of refraction is evaluated, the one that will prevent issues with vision and refraction. So we're mostly using the Barrett formula, which is the new generation one. It's more accurate, and in this case, we implement the following parameters. Also, we have a window for keratometry measurements, and that's how we evaluate the force. Also, among the formula, we also have the SRK with its modifications. In addition, I'd like to mention that for the anterior posterior axis, if we have evaluations that are not correct, this will lead to false evaluations in comparison to keratometry, because during the keratometry we will have a false keratometry for 0.8 to 1, but the difference for the first one will be up to 14 dioptria. And during the past time, there are studies among children in terms of multifocal intraocular lens implantations, and the studies are still continuing. And there are not many patients involved in this. In children, multifocal intraocular lenses don't have great advantage compared to the others. There are questions that are concerning their refraction changes and amblyopia worsening due to eye development and enlargement. And also, there is not that much experience with working with lenses in children. And we continue the best developments of science in this area. Thank you. Very shortly, everything was presented. Dr. Sarkisian shortly presented our understanding and our approaches, the main types of approaches that we use. These are the ones that we use during the traumatic, secondary, and innate cataract surgeries. And of course, I would like to hear my colleagues and what you think, what are your opinions on that. But overall, we have. So, as a surgeon that's working with pediatric surgery and has experience with that, and also a physician that has his role in this. So, the main issue that we try to avoid is obscuration, amblyopia, and we are anxious, especially if we have a monocular cataract. This is the most important issue that we try to prepare the child for surgery. And if the child has a combined other physical issue, a disease that will lead to the post-surgical when the child will have to receive intensive care after extubation, so the ICU has to take care of the child during the extubation. We're very happy also to have the Center of Excellence for Vision, and these children, the younger ones, like 8-10 weeks old children, if we have the need to do that, we will do that if we have to avoid obscuration and amblyopia. And primarily we try to do that. And secondarily, based on our own experience, I'd like to say that if the cataract is isolated and it's not combined with retrolental hyperplasia, or if it's not combined with familial exudative retinopathy, so if there are not any proliferative diseases of the fundus of retina. So in this perspective, this surgery will be more advantageous, because the optical axis will remain clear, and it will give us an opportunity, by removing the lens, it will give us an opportunity to reach the light to the fundus and show the first aid to the child. And this will help the child's vision and brain to develop better. In case of monocular cataract, as I already mentioned, when it's possible, we need to provide the child to sleep, and we can do this without intraocular implantation. And Dr. Sarkisian has already mentioned that we are not usually using the lenses in children up to 3 to 4 months. So firstly, we don't have that experience. And then we performed the contact correction. In the post-surgical area, we're using contact lenses because we want to avoid the anisotropy and anisometropic amblyopia. We want to avoid that as well. We follow up the child's eye growth functions, also the eyeball development as a visual organ is development. And if everything is well, at the age of 1, we continue with thinking, considering intraocular lenses implantation. If my colleagues have anything to say, or if you have a commentary, we'll be happy to hear your dear ophthalmologist, please.
Silverberg to comment when performing cataract surgery on young children. What your own and what commonly in the U.S. are the cutoffs for using IOLs, and also whether you target patients to be a little hyperopic. My understanding is we more typically aim for emetropia, typically in children. But please share your comments.
Yeah, no, thank you. First of all, I have to, with the disclaimer that I haven't, I used to do a lot of pediatric cataract surgery. I haven't done it in about 10 years because my practice is now almost all strabismus. But I can just make a few general comments if it's helpful. One is that usually in kids, like that chart you were showing with the rule of 7, we generally in the early stages aim for hyperopia because there's going to be a natural myopic shift in these children. So unlike adult cataract surgery, where you really want to aim for that perfect right on the mark emetropia, in pediatrics, it's actually the opposite, where you're aiming for hyperopic correction, knowing that the child will then grow into emetropia next few years. But the one thing I was going to add, if it's helpful, is that I think the cataract surgery itself is obviously an important component of the puzzle, but the main thing, believe it or not, is not the surgery itself, but it's the aftercare. And I've seen dozens of very well done cataract surgeries, either by myself or by my colleagues, who then the parents don't follow up well with the contact lens regimen or the patching and the amblyopia treatment, and you have a perfectly great surgery and then the kid is seeing 2400. So in my experience, the main thing is number one, getting the surgery done in a timely fashion, and your presentation really spoke to that. But then the second thing is getting the contact lens care done right away and very intensive patching. So the ones that have done well, and we have several in our practice of unilateral cataracts where the child is seeing 20/40 or 20/30 even. And those are always the parents that are very, very compulsive, and they're patching their kids between 6 and 8 hours a day, and it's a daily ritual. And then those kids do well versus the other ones who don't do the contacts, they don't patch, and the outcome is terrible.
Yes, I totally share your idea, and that's the whole issue, that maybe the surgery of cataract will have really nice outcomes, but if the eye is not closed, if you don't use the patch, if the parents are not following up, of course, the first issue is that we'll have amblyopia. And the second, I also share your thought that we do the hypocorrection because due to different causes, also in literature, we don't have that many evidence-based ideas why the eye has myopic changes after implantation, especially up to 2 years of age in the surgeries of cataract. And frequently, see, based on statistics, we can see myopic developments in those eyes, and that's why we perform hypocorrection. So firstly, considering the correction to not develop anisotropia compared to the other eye, so that the correction will be the same for both. And frequently, of course, in the eye, we see myopic changes that develop further. And that's why up to now, of course, I've been working with my colleagues that we need to create the hypocorrection. So the intraocular lens will have to be implemented with the force that will lead to hypocorrection, not emmetropy, especially if up to 3 to 4 years of age. So based on our experience, within some time, the anisometropy is increasing if we perform the emmetropization. On the other hand, if we have two different cataracts in two different eyes, but we could do that. But if it's monocular and if the other eye develops with its normal development, of course, we'll have to consider that the child will go to school and we understand that the difference in the vision shouldn't be too much when the child is writing or reading. So we don't want to see the child wearing contact lens above the implanted lens. And we want to avoid the amblyopy and also binocular vision disorders. And, that's very important for the child. And we know that the cataract surgeon becomes the family member for a family because you perform the surgery for an adult and you can maybe see this adult patient once or twice per year, but with the child, throughout the whole life, the child is followed up with his physician, changing the glasses and everything. The aim for this is to have high vision and to develop binocular vision. So the second important question, for me, this is problematic, and I'd like to know your opinions on this. So the accommodating intraocular lenses that for the future they work, are they actively used in the US for the little children? Do you actively use them?
In my experience, the multifocal and accommodating lenses are not used in children for a lot of the reasons that were brought up in the presentation. There's no great data on it, but the thinking is that first of all, with any decentration, which can easily happen in pediatric cataracts, you'd be looking at a lens that really could be inducing amblyopia rather than treating it. So I think that's probably one of the main things. And also, it just makes it a lot harder to target the hyperopic correction. And as the child moves toward emmetropia, it's going to be very unclear sort of what refractive target you're aiming at. So I think for those two reasons, at least up until now, the cataract surgeries have been that I've seen have been mostly monofocal lenses. John, do you have any comments?
Yeah, Mark, I would agree. Basically with everything you said. There's really one accommodating lens that is FDA approved in the United States, the crystal lens, which in adult patients is performs reasonably well, although the range of accommodation is not great. And the limit here in children is that you have a capsular bag that, as the child heals from surgery, can have some contraction that could cause decentration, and the optic with that lens is only 4.5 millimeters. So it's a small optic, and a small amount of decentration can cause problems, and also refractive error that is less predictable. Now, there are some future designs that are being evaluated in the United States, several companies with accommodating platforms that are promising in the adult population. but no implants globally, to my knowledge, have been performed in children. So we will have to wait and see. I think we're probably several steps away from having a truly accommodating lens in children because we're a couple of steps away from having them in adults at this point.
Yes, that's very important because so firstly we'll have to do that. So for the children, accommodation has to work, and that's why the children, that when they're going to school, they also require glasses. So their accommodation will be complemented. So mostly we like the hydrophobic monolens lenses, and the primary implantation is performed with monopiece lenses, and the most so the Acon lenses are mostly used here, but for the secondary implantation, we use MLAs as a source for secondary implantation, consisting of 3 particles, and they are used to put inside the cell site. So if you don't have anything to add, let's summarize the cataract as a pediatric as an area. Let's summarize this, which is always contemporary. It's always interesting, especially for the pediatric surgeon, and it's problematic because we have one aim to have good vision, high vision in those children. It's very important because everything starts with the younger age. If we are able to have that, then the future is ahead, and in that eye we can perform those actions that our research, the news in our research, they can offer us. Avoiding the amblyopia, this is the greatest issue in the patient with cataract that remains, especially in patients with monocular cataracts. So I think we should summarize this, and I would like to thank you for the discussion in this topic. Let's continue with the next topic. I think this may be more interesting to Dr. Silverberg, and would like to hear your opinion on this as well. The topic will be presented by our next pediatric ophthalmologist. She is pediatric ophthalmologist. She's working in our center, and the main topic is the vertical strabismus, in case of different patterns. Thank you. Hello. The topic today has already been presented, the exotropic strabismus with a vertical component and the methods for treatment. So usually the strabismus with horizontal and vertical components, it has certain patterns. So the pattern strabismus leads to the changes in the magnitude of horizontal deviation between up and down gaze. So we have 5 types of patterns: V, A, Y, X, and lambda patterns. So in terms of prevalence, NV patterns are usually more frequently observed, and they comprise about 15 to 20% of all horizontal strabismus. And the V pattern is, again, more common in these types. So let's talk about each one of these. So the V pattern is a type when during the up gaze there is a horizontal deviation, so it prevails. It's larger by 15 prism diopters, and it's different from the down gaze deviation. In case of A pattern, the same. During the down gaze, the deviation, horizontal deviation, is larger by 10 prism diopters compared to up gaze. The Y pattern is the case when there is an extra deviation during the up gaze, and this deviation is greater compared to a primary gaze and down gaze. X pattern is the extra deviation that is present in primary gaze. So in case of primary gaze angle, we can see extra deviation and increases during the up and down gazes. The lambda pattern is the case when it's a type of A pattern, and it's also increasing during the down gaze, but in the up gaze and primary gaze, we have the ortho position. We don't see any strabismus in this case. In terms of etiology, usually there are very different causes for the pattern strabismus, but these are the most frequently observed ones. So the most frequent one is the oblique muscle dysfunction, strabismus. This is the patterned strabismus, and particularly during the up gaze, when we have the over elevation in abduction, and we can also name this the hyperfunction of the lower oblique muscle, and this leads to V pattern. And on the other side, we have the upper oblique muscle when we will have over depression during the abduction. In this case, we refer to A pattern. The next cause may be any pathology in the orbital area. This may be neoplasms, also after trauma, when the trochlear system is damaged. So when the basis for the upper oblique muscle is damaged, and it leads to dysfunction, leading to pattern strabismus. Restrictive changes affecting horizontal rectus muscle, for example, lateral muscle contractures. In this case, frequently we can see X pattern when the contracture leads to the exotropy in the primary gaze, and when looking up and down, the deviation is increasing, and we can see the X pattern. Abnormal innervation may also lead to a pattern. It's usually the Y-patterned one. Also, when we're talking about the combined vertical and horizontal ones, we also need to talk about the dissociated vertical deviation, which is also DVD. This is basically the case when one eyeball is going up and the other one is fixating its gaze primarily. So we can see it in one and both eyes, and there may also be difference between the deviation angle between the two eyes. The three components are very important in this case. These are hyperdeviation, abduction, and also X-cyclotorsion. With this deviation, in case of dissociated vertical deviation, the patient the case will be latent when only the physician sees this during the cover and cover test, as well as this may be observed by the patient or by relatives when the patient is tired or after usage of alcohol, when they will see a shift of the eye upwards. In terms of etiology, we don't have the true causes for DVD. However, these are the most frequently observed ones. So the first one is the elastic preponderance in the elevator and depressor muscles, and this leads to the drift of the eye upwards, and also abnormalities of visual pathway and imbalance in binocular stimulation. This may also lead to DVD. So the treatment in these patterns and also in DVD, this is the experience and work in our clinics. So in case of V pattern, when we see hyperfunction of the lower oblique muscle, we will need to weaken the function of the lower one. Especially, we perform the Z myotomy of the lower muscle, and of course, the amount of the incision depends on the primary angle. If the angle is larger, we will need to understand whether we need to perform the transposition of the inferior oblique muscle. It will have A, B, and C levels. So A level is when the inferior oblique muscle is dissected from its physiological attachment, and it's attached to the lower rectus. In the second one, then we shifted lower by 2 millimeters from the inferior rectus. And the third one, when the distance is 4 millimeters lower. And also in V pattern, if there is a large horizontal angle in the primary vision, then we'll perform also recession of the lower rectus muscles. In A patterns, when there is an involvement of the superior oblique muscle, then the superior oblique muscle has to be weakened. And when there is no involvement of the superior oblique, we will just perform the transposition of the horizontal rectus muscles. In A pattern, it's not that preferable to work on the horizontal muscles, like not perform resection or recession. We usually try to perform the transposition. On this diagram, we perform the international experience. This is what the ophthalmological surgery. This is what is performed in the A and V patterns, and these are the kinds of transpositions of the rectus muscles. LR is the lateral rectus, and M is the medial rectus muscles. And appropriately, in case of A, what are the changes in A and B? These are the interventions during the surgery. In case of Y pattern, the treatment is performed by performing superior transposition of lateral rectus muscles when the transposition is moved upwards. And in X pattern, the surgery is performed on lateral rectus muscle. It's resected, and also if there is a vertical component during the primary gaze, then the lower muscle should also be weakened in order to fix the vertical component. In DVD, the treatment approach is a little different. It's connected to the vertical component presence in primary gaze, whether it's presence or absent. So in primary gaze, the vertical component, if it's evident, then the lower oblique muscle is dissected by Z myotonia, and it depends on the angle. And also we perform the lower oblique muscle transposition depending on the points A, B, and C. However, with age, in our approach, we have some differences. So in children that are in younger children, depending on the fact that the upper and lower oblique muscles, the development of this muscle is a little later, we performed it in 2 stages. So in the first stage, we perform the medial and lateral muscle recession, resection, and with a second stage, we fix the lower oblique muscle weakening and not involving the superior one. And on these images, you can see our latest patients. These are 2 clinical cases. This is the X pattern when the boy was referred with horizontal strabismus, and also we observed the X pattern. We performed the surgery, and the images are not that many because we couldn't take a photo in all kinds of cases also after the surgery, because these were the photos during the first day after the surgery. And in the left eye of this child, we performed the recession of the lateral rectus muscle, and we performed the transposition of the inferior oblique muscle as well. And this child is also one of our patients, and we observed the Y pattern. A surgery was performed to lateral rectus muscles. They were a little shifted, and you can see this is the muscle fixator. This is the lateral rectus muscle, which is lower than the physiological norm. And now you can see the normal physiological position, and also recession was performed. And as a result, this is what we can see after the surgery. This is the post-surgical first day. That's why we couldn't take the full photo, because the child had some painfulness. Thank you. Thank you, Dr. Balian, for this interesting topic. And we are expecting to hear experience from Dr. Silverberg. Of course, with these patterns, Strobology is one of the most difficult areas to work with because we can see innate and acquired changes of the muscle placement, and I'm sure that there are standard approaches. However, the individual approaches are also very important, and also the experience of the surgeon, strobologist. Anyways, we preserve the nullinosera, do not harm approach. We need to perform a surgery in a way that you can preserve central fixation for the child, central positioning, and if there is a need for future fixation, we will have a chance to do that. We don't want to have any iatrogenic changes that we will not be able to work with in the future. This is an important fact that I think that the surgeon, also it comes with experience. I think that the surgeon has to be able to provide a solution that even if we have an issue, we will be able to fix it. When you have a choice and you don't think that you don't have any alternate approaches, but maybe in the future you will be able to fix it in the future, and when the patient will have a vision. Yes, dear doctor, please, if you have anything to add.
Thank you so much. That was a fantastic presentation. And I would say that basically everything that you presented in your algorithm of strabismus treatment is basically what I do. It seems to be the same. I could perhaps offer a few comments. One is that with regard to pattern strabismus, especially in children, that I've sort of shifted over the years in my treatment of patterns. For example, Y patterns, which are somewhat common, not as common as V or A patterns, but with Y patterns, I've become much more conservative in treating these because I find that most kids, when they're looking up at their parents, the eyes will drift outward, and so it becomes cosmetically more of an issue. But as the child grows and they're not looking up quite as much, then it becomes less important. And personally, I find that when the child is orthophoric in primary position and in down gaze, I'm much less aggressive in terms of my surgical approach. But that's just my take on things. And then as far as DVD, I really enjoyed all the different options that you laid out. And I think, a similar approach, I generally try to shy away from operating on DVD unless it's very cosmetically noticeable. And if it is, I completely agree with your treatment options. And I find that working on the inferior oblique, it can be very helpful in these cases. And then also, of course, superior rectus recession as well. But in general, I think one of the things that I've learned over the years, and I have a lot of gray hair now, is that the inferior oblique surgery is very forgiving. And what I mean by that is you can, regardless of sort of where you put the inferior oblique, it tends to do pretty well. And maybe I'm not a good surgeon, so that could be the problem. But I think that I find that there's a lot of flexibility in where you put the inferior oblique, and you'll still get a very good result. So I used to be very obsessed with the millimeters on where I was putting the inferior oblique. And I find that, in most cases, regardless of where you put it, the kids tend to do very well, especially when they have a V pattern. So those are just a few thoughts, but I agree with everything that you presented. It was an excellent presentation.
Thank you for your idea. This is very important for us. Of course, it's very important that the fact that we consider the age of a child when we're working with the oblique muscles. Of course, we consider up to 10 to 12 years of age for the oblique muscle. So for the primary vision, if we don't have the vertical deviation, and if we see it only during the up gaze, we try not to intervene too much, because with time, up to 10 to 12 years of age, these oblique muscles then they tend to work synchronously by that age. And secondarily, so the experience that we collected throughout the years, if we work on one oblique muscle, you have to perform a tiny myotomia or Z myotomia on the other eye's oblique muscle, because in the other eye, you will have vertical component that comes from the central part, and this will affect the overall work. So if during the primary gaze, if in primary gaze we have a large drift that's vertical and the child is 10 to 12 years of age, not younger, if the child is not moving the head, that if there is not torticollis observed, then we will try to wait a little. However, if the child has a head tilt, also torticollis, neck issues, has head positioning, and when the head is shifted, then we have the movement of the eye upward. Of course, it's very difficult to work on the inferior oblique muscle, and especially it's hard to work on the superior oblique muscle, for example, in A pattern or in Brown syndrome, etc. However, in the other eye, if you have your experience with that, please share it with us. We also perform a Z myotomy on the other eye, or just anything, because the experience has shown that the one that you think it was fine, the child starts to develop the vertical drift, and this thing wasn't observed before the first surgery. So if we're working more radically on this eye, of course we never dissect the lower oblique muscle. We never just leave it like that. We always put some stitches and we fix on some sort of level, because we will be able to find it more easily in the future. However, in the other eye, we try to weaken we try to partially weaken the other eye's inferior oblique muscle, so we will see some equality in the primary gaze. It will be a one direct position. What's your idea, doctor?
So I would say 2 points. I agree with everything you're saying. And on your first point, I think if you think about the adult patients that we see, or that I see in my office, adults don't have pattern strabismus mostly, and so to your point, I think that most kids grow out of their pattern strabismus, and so that's why I think a conservative approach is often more favorable. But in terms of the second thing, I think what you're talking about is operating unilaterally versus bilaterally for these cases. There's no, in my experience, there's no single right answer. And vertical, inevitably, if you do one side, in a year or two, you're going to end up going back into the other side, especially for very large like DVDs and patterns. So I always explain to parents that I think of strabismus as the handles on a bicycle, and so you're trying to move them together. And so when parents ask me, "Oh, why are you? My child's eye, only one is going out. or going up or whatever, why are you operating on both eyes? And that's always the explanation that I give, is that, I want you to think about it like the handles on a bicycle, so where you're going to try to move them together. And most parents tend to understand that. But I think, it speaks to the problem of these vertical imbalances, that you try to fix it on one side, and then inevitably you end up with a problem on the other side. So you do end up, whether it's synchronous or asynchronous, you end up doing bilateral surgery. I was just going to add one other small point in case it's helpful for like that wonderful case you showed where the lateral rectus was displaced inferior. That's something that I really pay attention to, and that work was, a lot of it was pioneered at UCLA, as you know. And when I was training there, we really learned a lot about these pulleys and where they're, that pulley dysfunction and heterotopic placement of the recti can really be a major factor. So one little trick that I've learned in the operating room, in case it's helpful, is that when I start a case, if I'm suspicious of pulley dysfunction, when the patient is asleep and their eye is in the resting position, before I do any surgery or any forced duction or manipulation of the eye, I'll take a marker and I'll just mark the 12 o'clock and the 6 o'clock position, with the idea of anything I do after that, I can then see where the muscles are and how I'm shifting, if I'm causing torsion, if I'm moving the muscles relative to the center plane, is there true pulley heterotopia or not? So it's a very easy thing to do, and I don't do it routinely, but if in the back of my head I'm thinking, is this, am I going to move the lateral rectus or am I going to move the inferior oblique? And I have to make that decision. That's a little trick that I do just to kind of help myself know where the anatomy is.
That's a very nice idea. Thank you for sharing the experience. And we will fix this. I never marked 12 o'clock and 6 o'clock, but lately I've seen patients that when you get it on a muscle hug, you can see then the lateral rectal muscle, it's very oblique, and it decreases to 3 to 4 millimeters, and it's very oblique. And sometimes I told the patient, when I go outside of the surgical operator room, I will come out and tell you what happens. I'm going to do the intervention, but let's see which muscle I will be working on, how I will work, because sometimes we don't really know at this moment if the vertical placement is due to this oblique placement of the lateral rectus muscle. And when we perform the repositioning, when we do the calculation and make it balanced, then the placement of the eye is changing. And that's why we don't really have to do an intervention of the inferior oblique muscle. And we also had this in our practice. And up to that, and we haven't been thinking about inferior oblique before we fix the other muscles, because it may lead to a pattern that's problematic and that we see, and especially when the eye is placed in a superabduction way. This is very concerning when it's placed internally and upwards. So if the lateral rectus muscle, if it's in this place, but there is some vertical change, and in all cases you can see that the inferior oblique muscle is the culprit here. That's when we will be working on the inferior oblique muscle. This is the way we work, to be honest, and this needs to be studied all the time. However, it was very interesting to hear your experience and to get to know your experiences, and I hope that you'll have an opportunity to visit our center to see how we work, and we'll be happy to see how you share your experience. Dr. Vanessian, I hope that we'll have an opportunity. I hope that we'll have the meeting with Dr. Silverberg if he's all right with that.
So, yeah, let me just comment. First of all, this was really an excellent conference with high quality presentations. Both Doctors Balyan and Sarkisian did a really, really nice job presenting complex topics. Mark, I'm so glad you were here. I get double vision when I just think about strabismus. And so folks like you who are smart enough to understand it and be able to fix it are are a gift to us. Rosanna, thank you for your leadership and your the presentations that Doctors Balyan and Sarkisian gave are a credit to you as well for coaching them and teaching them. And you have a great department. You do fantastic work. To the Eye Care Project staff as well, thanks for putting this together. Well done. And to our translator, who I found incredible. I assume our translator was not an ophthalmologist, but I don't think I could have translated this from English to English. She did it from Armenian to English and backwards, what I could tell flawlessly. So this was really nicely done. Mark, I would echo the sentiment. We'd love to see you in Armenia. I'll send you information about it. We could certainly use your teaching both in surgery and in conference settings like this. So
it sounds like you like your doctors could be teaching me. So
I'm glad you are pleased. But the interchange is always really helpful, and the fellowship and the enjoyment of visiting Armenia is unparalleled. It's just a terrific experience for everybody who comes. We have a lot of docs coming this September, and we'll have a big trip next year as well. So I'll send you information about that.
Thank you. I'd appreciate that. Thank you.
Thanks to everybody who tuned in. I hope everybody learned something. I know I did.
I'm also grateful for organizing this beautiful meeting, and thank you. I'm also happy to get to know you again, Dr. Silverberg and Dr. Vanessian. Thank you for being here with us. I'm grateful to our colleagues, and I'm grateful to Armenian Eye Care Project. Thank you for organizing this. And let me just say the final words. Thank you all. I think that this was a very interesting and very active discussion, and I hope that we'll have similar meetings in the future as well. Thank you. We'll be waiting for you here.